home and I thought I had this, like we kind of all do, because we think about the labor, we think about the pregnancy, but then all your care kind of stops. I got discharged from the hospital. It had to have been like a week at least that he was in the NICU, and I remember leaving with him and crying because my hormones were crazy. He had just got off the antibiotics, and then they were like, okay, here you go. I was like, oh my God, what am I gonna do? And then I continued pump because my lactation consultant in the hospital had me pumping and breastfeeding, because if you have a NICU baby, you have some separation, you don't do that skin to skin, you're missing out on that initial stimulation. So my milk had just come in as well. And then I was like, okay, I was super engorged. I didn't know what to do. No one had guided me. So I just kept pumping and feeding and pumping and feeding and not sleeping, and I was not doing well. I had very bad postpartum depression, but I didn't know that that was what was going on. And then I was continued in this cycle of feeding, pumping, not sleeping.
So were you pumping just for extra? Like just to
I
store
was
up?
pumping because I didn't know what else to do. No one ever told me when to stop, and I never slept, and I was not good. And I didn't know that that was what was going on. I didn't realize that I needed to process that delivery, which was really difficult. It was traumatic, but I didn't think it was traumatic at the time.
Welcome to Birth from Within, where inner wisdom meets grounded preparation. We're here to share raw, real birth stories and offer the insight and tools you need to move through the system with courage, clarity, and authority. You were made for this. Your body knows what to do. This podcast is the heart work of a nurse and a perinatal chiropractor, women who have walked our own birth journeys, and now we walk beside you. In each episode, we share practical tools, grounded wisdom, and deep reverence for your body's design. Let's return to the root, because birth doesn't start in a delivery room, birth starts from within.
So today we welcome Alicia Cazzola. She is a former labor and delivery nurse for the last 23 years. She recently opened her own business of lactation and also turned into an IBCLC. So we are very excited to have you here.
We'd love to dive into some of your backstory, working in the hospital and obstetric setting for so long, and then to transition to your own practice. If you could just start maybe from the beginning of being a nurse and some of the transition in your story.
So, I mean, we can start from the very beginning when I decided to become a nurse. I decided to become a nurse when I was about 6 years old, and I got tubes put in my ears for chronic ear infections. And I had surgery. They put me under general anesthesia, and I woke up. I had a little bear with me, and they had bandaged my little bear's ears. And then I promptly threw up on the nurse. And the nurse was so wonderful. And she was like, oh, that's okay. I can remember this at 6 years old. And I said, you know what? That's what I want to do. That's what I want to do when I grow up.
It's awesome.
Fast forward, I went through college, 4-year program at UNC in Chapel Hill, and then I graduated.
Way to go. It's a really good program.
It was very difficult. And I had my first rotation actually in nursing school in the women's health unit. So I actually applied to be med-surg in women's health. And they interviewed me, and they said, I think you would be an excellent labor and delivery nurse. I actually really didn't know that was going to be on my radar. I thought I was going to work with kids, which I do, obviously. But I said, okay, I don't know why you've chosen me to do this, but I could probably parlay this into a lot of different options, because you can do triage, which I thought was like the ER. You could do C-sections, which is the OR. I could do labor and delivery. I could do postpartum. And then my first delivery, I completely fell in love. Wow. I delivered a baby, or I helped deliver a baby. The baby pooped all over me, which is kind of like full circle. And then I said, you know what, this is what I'm meant to do. And I worked in high risk. So I worked at Duke Hospital in North Carolina. So Duke was where you flew into to have your babies if you were high risk. We were known for doing bleeding disorders, preeclampsia, really interesting things that I hope to never ever see again. I did a lot of very high risk babies. So I was like indoctrinated into the high risk setting. So everybody who came in was on a lot of different drips, a lot of different medications. It was a very intense place, and I thrived on that. I loved it. I loved, first of all, like helping moms deliver. I loved seeing the babies and helping with breastfeeding and helping postpartum, but I also just loved the adrenaline of being there in the high risk setting. And I did that for many, many years.
It's awesome to start in a specialty, because I feel like in nursing, so often it's you got to get your due time in med surg and then you can specialize. So to be selected is a huge deal to start off the bat. And then also to be immersed into high risk, right? Like what's normal to you is the like
worst case scenario.
Worst case scenarios of what things can be as like your normal.
Yeah, it was. And when I got married while I was working at Duke, I got pregnant when I was working at Duke. And when I got pregnant, I realized that like looking around at my setting, I realized I didn't want to deliver there. I realized that if I delivered there, I would be high risk. There was no doubt about it in my mind. And I wouldn't be treated like a person. I would be treated like a number.
Can you break that down? That you would be treated high risk, do you feel like just because that's what the care teams there knew?
That is what we knew. That's how we treated everyone, like they were the worst case scenario. So I already knew that I did not want to deliver in the hospital that I worked at. At the same time, I really didn't know what a normal birth looked like. I really had no idea.
Did you even see a lot of vaginal deliveries?
We did see a lot of vaginal deliveries. I would say we saw significantly more C-sections, but I did a lot of vaginal deliveries there because we had some people that were lower risk, but they were still considered high risk. We did a whole lot of inductions. I cannot remember any, very, very rarely, unless it was preterm delivery, did someone come in and
just in like spontaneous labor.
Yes. Very rare.
Wow.
Very rare.
You were now having your son and trying to decide what does that look like and where am I going to go?
I chose a smaller community hospital, not too far away from where I lived. I chose a smaller medical group. I think they had 3 doctors. And I had my prenatal care through them. And they were wonderful. They were really great with me.
Did you pick the smaller practice for some reason?
Mostly because I knew that it was just going to be, I was going to be treated like I was high risk, even though I wasn't. And it was a lot of high turnover, and it just wasn't really, the hospital also wasn't like a cozy place to deliver. There were other more aesthetically pleasing and just softer places.
Which are what beautiful words when you're having a child, like cozy and soft. That does sound more appealing.
Even though the hospital that I delivered at, I wouldn't say it was nearly as cozy and soft as other options.
Yes.
Like it was significantly better.
It's going down the right trajectory. Okay.
So then I left Duke Hospital to work at that hospital during my pregnancy, actually.
Wow.
Is it because of the same thing? Like,
it was because of the same thing. I felt like I had learned a lot I think I was there for a little over 4 years. I had learned a lot in that position, and I had learned the worst case scenario, and then I felt like I wanted to see how normal people work. Still, we did a lot of medical interventions even at that hospital, but significantly less than at the high-risk hospital.
Yeah. Meaning you started to see spontaneous
I did.
labor. Like women came in labor. And
I did. And I got to do a lot more like hands-on care. So when I worked at the high-risk hospital, I did medication drips. I did continuous fetal monitoring, read the strips. I talked to the residents or the attendings there. But I didn't do a lot of cervical exams myself because it was a teaching hospital. So we had our residents do them, our med students do them.
Yeah, it's not necessarily your provider, it's people learning.
Yeah.
And so they're in your body, learning what it feels like to feel a cervix.
Yes, and sometimes it would be like 2 or 3 people like right after each other, which is like, that's super invasive.
We also have an episode on cervical checks, so it's awesome that you're bringing those up.
I wasn't even thinking about that, but I also worked in a hospital where there were students. Like I was a nursing student that was gawking at somebody like,
but it was like that was just what you did, and I don't think that their clientele really expected anything otherwise either.
Okay. Did you ever see a woman decline or request?
No.
No.
No, not there ever. Not that I can remember. However, that was 2001. So like that was a while ago. And I think that the obstetrical community has evolved in a positive way over those years, but definitely not. Yes.
So you went, had your baby.
So I had my son in 2006, and it was a perfectly normal pregnancy. I did have a lot of complications with my delivery though. I had chorioamnionitis, which is an infection around the fluid.
When did they find that out?
When I was admitted to the hospital. Everything was going normal. I actually worked the day on my son's due date. I worked that day because I had transitioned to the new hospital during the pregnancy, so I didn't have leave at that time. So I worked until the day he was due. That was fun.
Yes.
How did you prepare, or did you do anything while you were pregnant?
I did nothing to prepare. Nothing. Honestly, even being a labor and delivery nurse, I really didn't think about the preparation at all until that point. Like after I had my son, my life changed significantly. I thought I knew everything.
Yeah, you
I thought I'd seen high risk and I had seen some low risk at that point. I thought I knew how to handle labor. I knew I was going to go in. I was pretty sure I was going to get an epidural, but I didn't know that for sure. But I was pretty sure.
Yeah.
Honestly, the sad thing is I knew I was going to probably have a C-section because
Why?
I looked at my size, I looked at my belly, and I just had this thought that I was going to have a C-section. And probably because that was what I had seen in the past, right? Yeah. So I
now looking forward.
Now looking forward, I know that I could have prepared significantly better. Should I have another baby, which I won't. But should that happen, I would do things completely differently.
Can you share what would be those things?
Well, since I had my son, I learned a lot more about natural childbirth, and we can dive into that as well because there was a whole transition after I had my son. I would do chiropractic care. I would do my daily essentials for spinning babies. I would choose a provider that would support me in having a VBAC or try to support me as much as having a VBAC, which is hard to find. And I would probably have a completely different outlook. I think I would have a more rounded attitude towards it. I would say I would be more open. I think when you already go in having that thought process, it's
so mental.
It kind of preempts you to having that experience. So if you expect to have a negative experience or a certain type of experience, you likely will.
See, that's what we say, like the mental preparation, right? Like your brain is powerful. So if you're already like saying, like you're preparing to have an epidural, you probably end up having an epidural. Yeah. So you're saying,
or they even will see. I don't know for sure, but we'll see.
It's still basically preparing to have an epidural.
You're not choosing. You're still saying, right? I maybe that's still like. Whoop,
which to ask you, the hospital I worked at, I believe, was a 92% or 96% epidural rate. Like
oh my goodness,
very high, and high C-section rate, top of the national average.
I think that's what we were at the time.
So you weren't really seeing women that had you didn't see many physiological. No,
not unless someone came in and delivered right away with they
were just very ready, very close.
So in those hospitals, like the epidural was something that the doctor would come in. Okay, we're gonna have the epidural. Was it asked if you wanted an epidural? What was the conversation around that?
I think it was just expected that they would have an epidural. I honestly don't remember having an informed consent conversation with anyone at that point in my career. Yeah. Again, that was a long time ago. Well, in the grand scheme of things, it wasn't. But I mean, it was over 20 years ago. It wasn't until I started to move towards the smaller community hospitals and seeing more physiological birth that I saw less epidurals. But even there, I would say probably like 75%.
Wow.
As opposed to like 95%.
Yeah. So less, but still
high.
Way above average.
Oh, yes, definitely.
Over
and
half.
I'm pretty sure our C-section rate, even at the smaller community hospital, was over 30% at the time. But at that time, we weren't doing VBACs very often.
I was going to ask, when you said it was hard to find providers, because I'm trying to think, why do providers not want to?
Liability. It's all about liability with the medical system, and it's a shame.
Yeah.
But
is it higher risk to have a VBAC, or is it just more lack of experience?
it's lack of experience. So when I came out of nursing school in 2001, I think that was the year, or around that time was the time where they stopped teaching residents how to do VBACs or
Wow. So it's not even in medical school.
No, it wasn't even in medical school at that time. Wow. So if someone came in complete and like say breech, whatever, like
that's why probably people have the notion of once you have a C-section, everything will be a C-section. Because I know my mom has C-section because she had one C-section, then everything else was C-section.
Because isn't it higher, the more C-section you have, the higher risk you get.
Absolutely.
Really, right? Like so high risk.
Yes.
C-section is major surgery.
It is a major surgery.
Yeah, it's like everything is moved over, cut, and like however that body is healing back, can be hard.
But they definitely stopped doing vaginal breech deliveries about the time or before I started nursing. So that is a completely lost art. There's now a resurgence where they're trying to teach surgeons or OBs.
How did you get that mixed up?
But they're trying to. There's a group of more holistic providers that are trying to, but there's very few providers who want to take that course. In my opinion, it comes down mostly to liability.
And liability, maybe even like, how do you say, getting out of your comfort and you're easy, right?
Yeah, absolutely.
Breech can be...
It's more autopilot. Like, we know what to do, we know how this goes.
Yeah,
breech is maybe unpredictable.
It's unpredictable. I've been a part of 1 or 2 vaginal delivery breech, but in the past like 20 years, probably less than a handful. 1 or 2 of those, I was actually one of the more senior providers in that area and had to coordinate the care to get the providers in to have an imminent vaginal breech delivery. So that was interesting.
Dive into that. Like they didn't want to come in?
They didn't want to come in because I was a charge nurse at night in one of the smaller community hospitals that I've worked in the past, and providers didn't want to come in the middle of the night, so the nurses were kind of in charge, and so we would have to call the ER doctors to come up and do those deliveries, which they've really had no training on that.
So then you think we're hiring the expert, we're in great hands, right? Everybody goes to the hospital because they're like, I'm in the best place with the best care, and you're like, oh, not always.
Not always.
Yeah. So that begets the question, do you feel like you saw a huge contrast in C-sections in the day versus night and holidays versus not?
100%. Yes, 100%.
Yes, I remember our Christmases were very slow and our patient load, our ratios were much better because there was so much less.
It's crazy how the few days before Christmas, like there are so many babies on Christmas. Gosh, no babies come.
No babies.
So weird. And New Year's and 4th of July, it's all night shift. We have lots of babies at night shift, but that doesn't mean they're in the day shift.
More babies born vaginally?
Well, both actually during that time period. Sometimes after big meals, we do have more vaginal deliveries, like Thanksgiving and in 4th of July, because people get dehydrated and eat a lot, and then they have babies.
That's funny. Hydrate. So you transitioned to a hospital. We were talking about your delivery, but we didn't finish. You said there were a lot of complications.
I had a high leak of fluid, so that means that I had a very small break in the water, so it didn't present like this big gush. So when I went to the doctor's office that day, I said, well, I feel just a little bit of like wetness, and she did a nitrazine test, and she did a speculum, and she didn't see any leaking. So I went home and continued my day. By the time, I think it was like midnight, I was burning up. I didn't feel good. My water really truly broke at that time, and it was really thick meconium fluid. I felt terrible on my way into the hospital. I can remember almost passing out.
And what a defeating way to go into labor as a baseline, right? Preparation or not. You're just like, oh, that's hard.
It was really hard. I wasn't feeling many contractions at that time. Like all day I'd been kind of feeling like not so great, probably early labor, kept walking, walked the mall at the time because that's what we did.
Yeah.
And then I went in at midnight after my water broke, and when I was placed on the fetal monitor, his heart rate was 210 and it was a straight line. And I knew that was really bad news. Like that was a normal fetal heart rate's like less than like 160 usually.
Okay.
It's like 110 to 160, and we should have some variability, some up and down, and his was just a flat line. He didn't have any dips in the heart rate, which was really good, but it was a flat line, which is ominous basically.
When you say flat
It
lines,
was so not
So
a
you're saying it
lot
stayed at
of
210, like it was just
was
staying
a-
high.
Yeah, so flatline, when you think flatline, or when most people think flatline, they think like a cardiac rhythm, and flatline is like dead. That's not the case with babies. We're looking at their average fluctuations in their heart rate. So when we get excited, happy, whatever, our heart rate goes up. Same with babies. But if we are not feeling well, if we are not doing well, we don't see a lot of that fluctuation. So when you put it
As the mom? Also, or the baby?
in
Or
general,
both? Yeah.
we in general, like if we are sick, our heart rate doesn't fluctuate much either. But when babies are not doing well, we see less of that fluctuation.
So that's where you're saying that actually, with what you know, that is a cause for alarm because
was a cause for alarm.
we're looking for the variability.
Correct. So no dips in the heart rate, which was good because that would have been significantly more alarming, but it was no variability. And the heart rate was significantly higher than it should have been. So I was on pretty high alert, but I was also not myself and couldn't really think of what the next steps were. My nurses that I worked with were my friends. They dropped everything, and everything was all about me. They tried a lot of different things, so I ended up with triple antibiotics, which is ampicillin, clindamycin, gentamicin, to help fight infection
because of that was already happening.
because the infection was already diagnosed. Like my temperature was I was febrile.
Or you think that was because your water was maybe broken a long time?
I feel like my water was probably broken longer,
and then
it
do you feel
wasn't
like the check
recognized.
that she did, because it wasn't recognized, could that have contributed?
Yes, but yes.
Because right, you're higher risk of checking internally once your water's broken.
Right. Yes, it does increase. So when we did a cervical exam at that point, it definitely could have introduced like bacteria into the vagina. If my water was broken, that would have increased that risk significantly. Yes. But I don't know. I think it was just such a high leak at the time that she wasn't able to diagnose it. And it's not a very common thing because usually when we do like 3 different tests to see if the water's broken. If we do those 3 different tests and they're all negative, then we feel okay, like it's something else. It's like vaginal discharge, something else. But if it's a high leak and it's not very much fluid, then sometimes those can be negative. So I think it was honestly just really not bad
Nurse
luck.
Yeah, unlucky. Yeah, you say nurse luck.
Yeah, that's what we call it. Nurse curse is what we call it, which is terrible. So I don't necessarily blame the physician there at all. And in fact,
I wasn't meaning to blame her, just that you couldn't have known. She couldn't have known
she
either.
couldn't have known. And I guess it just brings the point up that like our testing isn't 100% accurate, including that fetal heart rate. And the testing, like there's always going to be outliers, and I was one of those outliers.
Yeah. Like the testing that missed that your water broke.
Yes.
So that was amniotic fluid being discharged, but
even when you have a cervical check.
Yeah, you wouldn't necessarily see that on a cervical exam. But yes, doing the cervical exam definitely didn't help the situation.
Yeah. Okay.
But then I was in labor and I knew it wasn't very good. She did try her hardest to help me along to have a vaginal delivery.
And with
So I'm
feeling so
really
crummy,
thankful.
What about an epidural? Did you get that early?
I did end up getting an epidural because I was looking at the big picture of things. And I said, okay, well, by the time I got the epidural, we tried other interventions. So we tried to start Pitocin. My contractions were like almost non-stop. I didn't feel them like as hard and strong as
Before the Pitocin?
before the Pitocin. They were already pretty close. After the Pitocin, they really didn't stop. So they ended up having to turn the Pitocin off because I was not getting any break.
Do you think that can contribute to fetal distress? If
Absolutely.
The baby, right? If you're not getting a break, baby's not getting a break.
100%. So like she did try.
Yeah.
But yeah, we probably tried a little more than we should have. She did put internal monitors in, which would increase that risk of infection as well. But she was trying to see, were these contractions, were they actually as strong as they look like on me? Because I am also a very small person.
Yes.
So when you put the tachometer, the contraction monitor on me, they're going to look like they're bigger than they might be. So the internal monitor would measure how strong they were.
Okay.
But the internal monitor...
Is that the one that goes into the baby's head?
So that's
different.
So I had both.
Okay.
I had the FSC, fetal scalp electrode, which is the one that goes into the scalp. I also had an IUPC, intrauterine pressure catheter, that goes between the uterus and the baby to measure how strong the contractions were.
There's a lot of stuff going on.
It was a lot of stuff.
And you're feeling crummy.
It was a lot of stuff.
Yeah.
But she was really trying to get a good picture of like,
Yeah.
were these my contractions? Were these not? Could I proceed with a vaginal delivery? And when she placed the internal monitor, there was a lot of bleeding. And then I said, you know what, this is really, like, this was kind of bad news. Now it's really bad news.
And you probably have so much anxiety knowing
I did.
where this can go.
Yeah,
You've seen it so many times, right? And that's so that you're going to go right to that.
I did.
Every
I went
worst
right to the worst case scenario, right?
So bad. That's so hard.
So I powwowed with like the nurses that I worked with and the doctors, and they said, hey, let's get you an epidural preemptively, because if this goes worse, we're going to have to do general anesthesia, which means put you to sleep, and then you won't be able to see your baby, and it's more medical complications. So I was like, you know what, like, risk versus benefit. Like, I at least was sane enough at that time to say, all right, like, this makes sense.
Yes.
And they did an epidural about 6:30 in the morning. Everybody powwowed again. And so I worked a night shift at that time. So we leave at 7, right? So my charge nurse, everybody talked, and we were like, you know what? This is not progressing. My cervix was 3 centimeters. It was 3 centimeters in the office. It was 3 centimeters when the internal monitors were placed. Now this is fast forwarding to over 6 hours later, and the cervix was still the same. The heart rate was still the same, even after like everything that they had done. It did come down. I remember my husband saying, oh, his heart rate is 180 now. And I was like, oh, that's slightly better. But in the end, 6:30 in the morning, everybody talked, and I was part of that conversation. So I really felt lucky that I worked in that environment.
Yes.
I was part of that
So you
conversation.
felt empowered in the decision.
I did.
Which is great.
I did. Even though
But still, I guess you were freaking out.
I was
inside.
very much freaking out.
Yes.
And so we proceeded with the cesarean section.
And do you also think your body, just like there's so much happening to you on top of like baseline you weren't feeling well, but I just think of all those things in you of like
it was
stalling. I don't know if we would say labor stalling, right? But not progressing,
right.
But,
also
like how much
cervical
internal
checks, right? Like
cervical
she's-
checks, the catheter in there,
Yeah.
the fetus. What is it called? What it goes in?
Fetal
the head?
scalp electrode, the
Yeah,
IUPC.
Antibiotics running,
was a
epidural. Then so
lot.
you're very attached with a lot of
very
things
attached.
happening to you. Like that is.
It was a lot.
To give you, that's so much happening
a
to your
lot.
poor body.
It was a lot.
For her
then-
and her baby.
For
too.
both. But I mean, you know, at the time, like looking back, there were things I probably would have changed. The outcome, honestly, I feel very confident. And maybe it was because everybody sat and talked to me.
Yeah.
And I was part of that conversation. And because I had the knowledge that I did, that I think it was the right move at that time.
So can you go in with just an epidural and have a C-section?
Yes.
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 That's it. Which is wild than women.
Absolutely.
What about women that say it doesn't work?
So then we redo it or we dose it up. So with an epidural, the epidural catheter goes in and it gives a constant infusion of medication. What the epidural is supposed to do is make you like 3/4 of the way numb. So you're supposed to feel enough that you can push when it comes to
pressure on the
pushing.
body.
Yeah, you're supposed to feel the pressure, but you're not supposed to feel that as much of the tightening contraction pain. So when you have a cesarean section and you've had an epidural, you dose up that epidural to get it higher block.
So you're not worried that it's not going to work. Okay. Wow.
So-
okay. So then you got to be awake.
I was awake, which was really great.
yes.
So I can remember going in, I remember the decision being made. Honestly, most of the rest of the stay, it was like curtains. I remember certain things. So I still have a scar from my IV.
Wow.
Right there. Amy placed that IV 19
work,
years
Amy.
ago. And
19?
19.
Wow.
So I remember that, and then I don't remember anything. It was like a curtain. And I don't
Took
know if
over
I
your
was
memory and literally.
I don't know if it was literally, I can't remember anything.
Wow.
For a couple hours. And then I remember one of my other coworkers came in and was trying to cheer me up because she was like, Alicia's stressed. She showed me pictures of her son who just gotten married, and that was really nice.
Yes,
I was going to say, was that helpful?
It was helpful because these were my friends I was surrounded by. So it's
So you're
different.
in a place that people you trusted and cared about
I
you.
trusted and I loved these people, and I knew that they loved me. So like it is different.
Yeah. So
like the average person coming into labor wouldn't have that experience, but I did.
So your goal was to have a vaginal birth.
It was.
But as soon as, everything changed, what changed in you to be, like, did you tell yourself something? How did you do that change to not feel guilty or
there was a couple things. One, I knew what was going on. Like, even though I didn't feel well, even though I was not in my right state of mind, I could still use my clinical judgment, which, most people don't have, but I did. So I felt good, like, knowing, okay, these are signs we would normally go for a C-section at this time. I also felt like I was being supported by my provider because she did attempt to do a vaginal delivery, even though maybe in hindsight some of those things were not needed. Because right now, like in the last couple of years, we probably wouldn't have done that IPC. We probably wouldn't have done that fetal heart rate, like the FSC. But I did feel like at that time she was trying really hard. And I felt like I was part of that conversation, that it was not just something going on at the nurse's station behind me. While I know it was still going on in the nurse's station behind me, I did feel like I was part of that conversation. So in the end, I did feel like it was a good decision. I felt empowered. I felt good about that decision.
I mean, I believe everything happens for a bigger reason, which I can see now how you now support women going through all of this stuff. That's like the best wisdom you can give them because you went through all of that.
I did.
Too. Yeah.
I did. So I feel like I can support those who've had to go through those hard things. And I can also support and realize and recognize that that is not the norm. Like, this is not the norm. My situation was worst case scenario. Well, not worst case scenario, but it was a really not a great situation.
Well, but even with C-sections, we're thankful they exist because there are true emergent situations. So it's not saying this is the pure evil. It's saying we've gotten to the place where there's so many non-emergent situations. And
we have. We have.
So continue.
So then my son went to, I can remember being in the OR. I can remember everybody was really supportive. The doctors, the nurses there, they were joking and they were trying to keep the spirits up. The NICU team came in. I remember him, my husband, in his cute little hat. It was the cutest he's ever looked. I was probably delusional. He got to look over the little drape and see him, and he was like, oh, he looks good. And then they pulled him around so I could see him. I was like, oh, wow, he does not look good. So he went to the little stabilization room. He got stabilized. He was transported to the NICU, and he stayed in the NICU. I think it was about 2 weeks, but again, it was similar. Like, I kind of disassociated. Like, I don't remember much, except for when I went to the NICU with him. But they did support me. He was on oxygen. He was on antibiotics, triple antibiotics as well. So yeah, he has a very terrible gut. And so do I. So we do have long-term repercussions from this, though, because of, these antibiotics, and he wasn't exposed to the vaginal flora, which is a whole thing.
Yeah. Which, can you say that? Can you just...
Yeah, well, when a baby comes out vaginally, they are exposed to your vaginal flora, so your vaginal bacteria and fecal bacteria, so like your stool. But this helps to colonize their gut and their skin so that it gives them long-term protection for autoimmune issues later in life, allergies, asthma, because we have good gut bacteria and we have bad gut bacteria. If we're colonizing with good gut bacteria from the beginning, with a vaginal delivery, with colostrum and breast milk, we are preventing, hopefully, or decreasing that risk significantly for
this chronic
gut
diseases then.
Permeability.
For gut permeability issues, for for
and
an
the
optimal gut health.
colostrum, right? It has the sick A that patches up your
so
gut.
cool.
Yeah, yeah.
Wow.
It's so very cool.
Also interesting, we always go back to poop here.
Yes.
But I know, like the vaginal swab, but I actually hadn't heard somebody say like that, because there's so much fear of pooping, and then you're also like, why? But to get so comfortable, because just saying, like, I had a huge fear of like, what if I poop and I'm so embarrassed, and I'm like, don't share that with anyone.
But it's so good.
Yes, and just saying like, yes, they keep it kind of away from the baby, but you're like, oh, that's not hurting your baby.
No.
Like, actually, oh my gosh, that can give them a lifeline of immune support for life. So
it's so cool.
All the more reason to feel comfortable pooping, so you can just
It's so cool. I went to a microbiome convention last year. It was a virtual convention where they showed all of the new recent studies on like gut health and how to protect your microbiome, which is like your gut bacteria, from pre-birth all the way until you're an adult. So it was really neat, and it just confirmed a lot of things that I already knew. Like even the new recent studies say how amazing vaginal delivery is, how amazing that colostrum is for coating the gut for long-term health. It's pretty cool.
Yeah.
Wow.
And even if you have, like, there are other options, because even if you have a C-section now, I mean,
There are other options.
It's
Super
still like you can
controversial.
inoculate your baby with, still it's a little bit gross, you would say, but really it's giving them what they didn't
When you say
get.
gross, you're saying a swab, a vaginal
So I'm saying
swab.
vaginal swab
yeah.
and put it in the mouth and like.
So interesting thing, in the conference that I went to last year, they actually said that wasn't enough, and it was the fecal transplant that made the bigger difference. So
okay, how do you do it then? If you're having after a C-section.
So that we can do. We can still we can do vaginal seeding. That is a thing.
Did you do that?
I did not, because I did not know that was a thing at all.
Okay.
Like I had
You say
no
controversial.
idea.
I'm like, I feel like I tell women this is an option. It's good to go in with a plan of things you
I
can
would
do.
say
But
if
I've
you
never
go-
heard of it was done before.
So I used to work in Boca Raton, and we actually did have quite a few people who did vaginal seeding after cesarean
What
section.
is the process?
So you take a gauze and you put it into the vagina and you let it sit there, and then you write that on your baby. Well, this was like 8 years ago. No, probably 10. And some people were like actually putting it into the baby's mouth. That was like a no-go.
So like the person would
at the hospital.
The person will do it,
too
or
unsanitary.
So the mother would do that, because that is definitely not something that the staff is going to advocate for.
So you do that yourself. It's just
You
you
do
go
that
in and
yourself.
you're going to do it. Okay.
Yeah.
Not like, this is my birth plan. Please do this for me.
No, but funny enough, I was just printing up birth plans yesterday, and that was on one of the birth plans. I was getting ready to go. I was going to do a class with some teenagers, and that was on the birth plan.
Wow.
So, but you're saying that's not enough. So
it's
how
not
would you do
enough.
the other parts?
So there was mixed reviews on the studies of how you do it that way. So the way in the rat studies, they were actually doing fecal transplants. So they would actually feed the rats which is not really ethical to do as a study in the United States or any other country. So they haven't produced those same effects in women. But what they said, a couple of the other studies I was reading was if we put it on our skin, so if we do the vaginal seeding, and it could be like from front to back, like so.
Like you're wiping.
Yeah. And then you
can
put it on
describe
your
it, because I'm interested in how is all of this done.
So you wipe, right? So you have to get a little bit of everything there, and then you put
Like
it on
you're
your
wiping,
skin right after you deliver, because they're
Oh,
gonna
right
have
after
all
you
the things.
deliver.
Yeah,
Sorry,
yeah.
this is, in the moment of labor.
So,
not.
So this is a study. I do not remember where it was, but I did I saw the presenter of this study. It was one study. So again, not a meta-analysis, not a huge, the research world is not going to approve
Not
this
gold
one.
standard research.
Definitely not. But what they said was, if you do like a swipe, so you go from top to bottom after you've delivered. So this is not after you poop, this is after you deliver. But there's going to be, theoretically, there would be some fecal, and then you put it on your chest, and then you put your baby on your chest. It's that skin to skin, that transfer, and then the baby does its little breast crawl, and then kind of gets it on their hands, and then they get it in their mouth, and then that's the way to get that bacteria.
Wow. Wow.
I told you I am a wealth of knowledge.
I love it. Yes.
Is that so weird? But I do know a lot about weird things.
It's also good getting over. It's like hear it now because so many things like that. I just remember years ago, and you're just like, ew.
normalized.
So when you say gross, but you.
I remember like when that concept came around, and I'm gonna say it was about 10 years ago that I first heard of it. That was coincidentally about the same time I started meeting doulas in the hospital setting. Wow. And it was a very like controversial subject. So my patients who would do that, they would have to do that like, you don't tell. I was like don't tell me, please don't tell me, because then I have to report this off, and then that's going to be a whole thing. They're going to swab your baby, they're going to do all these crazy things. Wow. So don't do that.
So if you are doing it, maybe don't put it in your birth plan and just do it.
I think things have changed a little bit, but I've also think that vaginal seeding has kind of gone out of favor. Like I haven't had as many patients in the hospital or clients prenatally that I've met for like childbirth classes who've talked about doing that, but
it is a thing.
I know it's a thing. Oh yeah, it's a thing.
In my birth, I put part of the placenta in my mouth. Like after delivering the placenta, my midwife caught a little bit of placenta and then put it in my mouth. Because it helped with like the change of hormones and the stop the bleeding and
we used to make, well, not me, the doulas that I worked with in South Florida, they would make placenta smoothies and right after delivery. There's some controversial information I've learned recently on that too, so that's been really interesting in the lactation world.
We were in vaginal seeding. Now we
my gosh, we have gone super off topic.
Recap. We're done with your birth. Now you are working.
He's in the NICU. He used to work there. And I went home and I thought I had this. Like we kind of all do, because we think about the labor, we think about the pregnancy, but then all your care kind of stops. I got discharged from the hospital. It had to have been like a week at least that he was in the NICU, and I remember leaving with him and crying because my hormones were crazy. But then also he was like still like he wasn't like fully healthy. Like he just came off of all his, all his antibiotics and all of his, they were monitoring his heart rate too, because he had a PDA, which is like a little flap between his aortas hadn't completely closed. So he had a little murmur. So I knew he had that. They were monitoring that. He had just got off the antibiotics, and then they were like, okay, here you go.
It wasn't more like a sleepy baby, not like a
he was pretty vigorous. He was pretty normal, like as far as babies are concerned.
But he was all your knowledge of what had happened.
He was 7'3", so 7 pounds 3 ounces. So he wasn't like a big baby. He wasn't a really small baby. But I did remember going home and saying, okay, I have this baby. I know how to keep him alive for about 3 days because I work postpartum.
I need postpartum education. We're like, after 4 days, I don't know a thing.
So then I remember crying on my way out because I was like, oh my God, what am I going to do?
You already passed 4 days.
And then I continued pump because my lactation consultant in the hospital had me pumping and breastfeeding, because if you have a NICU baby, you have some separation, you don't do that skin to skin, you're missing out on that initial stimulation. So my milk had just come in as well. And then I was like, okay, I was super engorged. I didn't know what to do. No one had guided me. So I just kept pumping and feeding and pumping and feeding and not sleeping. And I did that for about 2 more weeks. And I had pretty bad postpartum depression. And I didn't have a lot of help. My husband had just taken a new job. He had gone off to work. So I was there all day. And then he would pick up at night. My poor saint of a husband. Saint of a husband.
Way to go.
He helped me at night, and in the afternoons I can remember like 3 o'clock I would be like crazy, and I'd be like, okay, you have to come home. I don't know what I'm gonna do if you don't come home. And so he would come home early sometimes and help me out, and we'd leave the house, we'd take little walks, but I was not doing well. I had very bad postpartum depression, but I didn't know that that was what was going on. And then I was continued in the cycle of feeding, pumping, not sleeping.
So
and then eventually I got out of that.
No.
I did bottles, but not a whole lot. Like in NICU I did because he had to have them.
So were you pumping just for extra? Like just to
I was
store up?
pumping because I didn't know what else to do. No one ever told me when to stop. And I didn't know when to,
So So also if you're pumping and feeding, you probably had so much
I
milk.
was so engorged.
Oh my
and
gosh.
I had way oversupply, which again, like over is better than under, so I was real happy.
So the point was because of the NICU you were pumping, but
Yes.
what should have happened is you stopped pumping
eventually,
and nurse normally.
once I was not having to give him that extra supplementation, so once he was healthy enough to take, we should have been transitioning to just breastfeeding, but I didn't know when to stop that. No one ever guided me, so I just kept doing it, and I never slept, and I was not good.
It's so much work. That's so much work.
I was not feeling
Breastfeeding's
good.
hard, but you're not cleaning anything.
Oh my gosh.
Yeah.
Versus pumping, it brings a whole other dynamic, and if you're doing both.
Yeah, and I don't think I was even giving bottles at that point. I think I was just breastfeeding and then just saving it. So we had like,
Oh wow.
our whole freezer was full.
So and then
Definite
you
supply.
said postpartum depression, like
Good.
they don't screen you for that in the hospital, and then you have to wait
They-
6 weeks, right, for your.
At that time you did. You had to wait 6 weeks. Now we have most OBs, not all, have a screening for postpartum depression about 2 weeks. And then they do one at 6 weeks. But yeah, nobody was there to screen me at that point or to guide me, and I was just kind of doing what I needed to do. And I didn't know that that was what was going on. I didn't realize that I needed to process that delivery, which was really
Traumatic.
difficult. It was traumatic, but I didn't think it was traumatic at the time.
Yes. Yeah.
Since working through it, I realized how traumatic it was.
So for people that could be going through that, what would through postpartum depression, can you share some of the signs that they can look for? Probably another episode,
It is a completely different episode.
just quick, what are some signs of that?
Some big red flags are having difficulty sleeping, even if you have the time to sleep. So taking out the fact that babies don't sleep a lot, but if you are having to sit and watch your baby and worried that your baby's not going to breathe, or if you just really are so amped up that you cannot sleep, that's a pretty big red flag.
So pretty paired with anxiety, like really high anxiety.
Yeah, which I see more of anxiety when I do postpartum visits than I do with depression now. If we're having difficulty relationship-wise, so with anybody, like with your family, if you're having difficulty bonding with your baby, that would be a big red flag too. There's a lot.
Yes.
There's an Edinburgh questionnaire that most postpartum providers will have when they go to your home or when you go to your postpartum visit. Problem with offering it in the hospital is most people aren't feeling that yet. So it doesn't kick in usually for a week. Honestly, it is about 2 weeks. So 2 weeks is a really good time to do the Edinburgh scale and then follow it up like every week or two because things do fluctuate significantly postpartum.
You just think of the touch points before you have your baby. What you're saying, like every week you have an appointment until you deliver, and then after you're just thrown. Even I had a home birth, and I feel like the care was unbelievable. But afterwards, I think you get even less. I feel like you get less support even.
You do
Like,
well. Yeah, it depends on your provider.
it depends on your provider. And like I could have sought it out more, but I didn't know that either. So I just feel like you're kind of floundering, and maybe they're available to you, but you still have 1 or 2 appointments in the next 6 weeks. Like not a lot.
I'm also integrating that in practice. I didn't know about this until a recent seminar that I took. But like also 2 weeks is when I tell moms, bring your baby back, because that's when babies are going to show, preference for one or the other and stuff. But also important to screen mom there, because if those moms are waiting for those 6 weeks, then I see that opportunity.
Yeah, that's a month. That's a long time.
We can get a lot of support before then, and sometimes it's like really urgent, like that you need that support. So personally, that's part of the reason, that more so than anything is why I moved into doing what I do, because I had that experience and I see the importance of coming to the home and seeing my clients on a regular basis to, yes, check on lactation, but also check on the mental health, physical health of babies and moms, because things change in a few days' time. So I like to kind of follow up like on a pretty regular basis. And actually, I like to do like 2 visits in the first week to just make sure we're okay, because from one day the milk isn't in to the next day the milk is in, there's a big change lactation wise and how you're feeling, and it makes a big difference. And then I like to do another one in a few days once we've kind of cleared that up, just to check in and make sure we're still heading on a good path.
But you go to the home.
I do.
Oh, it's amazing.
You were also holding breastfeeding support groups
Yes.
at the hospital?
I was at the hospital, so that was later. So we've gotten until my son was born, so that was 19 years ago.
Making good time.
Shortly afterwards, we moved to South Florida. And South Florida, I worked at a couple different hospitals. So I worked in the night shift where I was the head nurse there, and that's where I did some vaginal breech deliveries. That's where I really did everything.
Did that blow your mind to do a vaginal breech delivery and be like, oh, it's possible? Or
I was
it
panicked.
Okay.
I'm not gonna lie, it was so insanely stressful.
Yeah.
But luckily, I had just read Ina May's guide to
always come back to that one
birth.
too. Yes,
And in one of her books, I'm not sure which one it is, but one of them, it actually lines up what do you do for a vaginal breech delivery.
And you just read it?
So I just read it.
That's amazing.
So that was kind of your guide.
I did not do that delivery. I watched, but I was ready to hop in.
Wow.
So that's about when I started to get into more natural birth, because I saw the medical side, I experienced the medical side, I had my postpartum recovery, and then I wasn't in my right state of mind for 2 years. I struggled with postpartum depression for at least 2 years.
How early did you go back to work?
8 weeks.
Was that again lack of support?
It was a lot of lack of support. It was also me just not recognizing the red flags. So I wasn't bonding with my son the way I wanted to. I mean, we had a good relationship. We still have a great relationship, but it wasn't like how I had pictured it. It wasn't like, we spent hours snuggling and breastfeeding. It was very stressful. And I do think that affected some things for him long term, honestly. But it affected mine and my husband's relationship a lot.
Because you weren't yourself.
I wasn't myself, and I was very mean. Anybody who knows me knows that I am not a mean person. I'm probably one of the nicest people.
Yeah.
But I was very mean to my poor sweet saint of a husband. I also wasn't sleeping.
Which makes anybody mean.
Yeah. So I didn't recognize all the big red flags for about 2 years until I was coming out of it, until he was a little bit more independent.
So you didn't get any support?
Yeah, I was going to ask the same
2 years. I was going to ask how long it lasted.
No
2
support.
years.
And during that time, we
moved.
Oh my God. I changed jobs twice. It wasn't until I got into a stable routine. So I started to work. He was about 2 years old. I changed to a day shift position where I could actually sleep at night. Yeah. I started to work out. I started to prioritize my health and my diet. And then I realized once I started to do that, I was myself again, or a lot more like myself. And then I also learned about natural labor about that same time. I'm not learned about, but I learned a lot more. Yeah. That was when I started to meet doulas and started to take spinning babies classes before anybody knew what that was.
What is that?
Spinning babies? Spinning babies is awesome. A lot of health providers take it, so chiropractics, nurses.
No, body workers that are in the birth community.
Yeah, birth workers, doulas will take it. And it's body balancing, so it teaches stretches, positions that can help facilitate labor.
So it's a thing you would do when you're pregnant?
Yes.
Okay.
Yeah. So I took that, I implemented that into my care at the hospital to try to decrease my C-section rate for my patients. I took that way before.
How did the hospital take that?
Oh my gosh. So that hospital was fine with it. That hospital was actually it was a pretty progressive hospital. We had doulas there. Any other hospital I had worked at prior, I had never met a doula, ever.
Wow.
I had never met a midwife, certified nurse midwife, but I had never met a home birth midwife ever. So that hospital was much more progressive, and that was a wonderful place to work. So they were very supportive of that. They didn't know what I was doing, but they were just okay, you do it. You do you, Alicia.
So as you started learning about natural birth, more about that, and spinning babies, other stuff you're incorporating, can you talk about the difference of your care as a nurse in the past hospitals to this and birth outcomes?
When I started to advocate for movement, and when I tried to was advocating more for intermittent fetal monitor, which was hard for me to even accept at first. When I started learning spinning babies and getting movement is so
movement is life.
Crucial.
Movement is life.
And we don't do it enough. I did see the C-section rates, and anecdotally, because I wasn't keeping track, but I did see C-section rates go down in my clients. I would see some pretty amazing changes. Like the doctor would be like, okay, we've got X amount of time before we have to go for a C-section. And then I would do all of my things, and like we would be pushing before that X amount of time, and that made me so happy.
That's amazing.
So happy.
Was some of that, you're saying, like getting your women up and moving, changing positions?
Mostly movement.
Wow.
I mean, it wasn't always preventative, but it definitely helped significantly.
So one of the biggest things after your son, I don't know what year this is, but we're going to call it your pre and post, like the change to helping women achieve a natural labor. Were you just seeing everyone was on their back, and
Everybody
now you're
was
letting
on their
them?
back. Everybody, yes.
Wow. And so that would be the biggest.
That was the biggest
factor.
thing. Yeah. Wow. That was the very biggest factor.
So what position changes? Can you talk about a few?
At that time, I wasn't doing anything major. I was doing a lot of side lying, and there's a position called side lying release where you kind of line someone up like on their side and then let the top leg kind of dangle off the bed, and then you do like a little, we call it myofascial release right now, but it was just like a little vibration, like a little massage in like the hip area, and that releases some pelvic muscles and the psoas, which is a big ligament here, and then when that loosens, then the baby has more mobility. So then it has an ability to flip, or in the cases at the hospital, it was just rotate down.
So even still in the bed,
yeah,
you're keeping them
I
there.
was just doing that. Yeah. And then we had one monitor that could be portable at that time. So it was like a monitor on a cart. And I can remember having one client or one patient who was like, I want to move around, but the doctor was like, no, we have to have continuous monitoring. So I hooked her to that, and then I walked her.
That's amazing.
And she did the electric slide.
So you had to you were now a little different. Yeah. Were other nurses on board, like kind of alongside you? And
depended on the nurse.
Okay.
Depended on the nurse. I was lucky at that hospital. That's where I met a lot more midwives, and they were pairing with doulas. So I was really lucky that that was the place to be. In South Florida, if you lived in a 30 to 45 minute radius, this was the hospital that you wanted to deliver at if you wanted a natural birth. So I was lucky there. They were really supportive. They were awesome. And then I moved to North Florida, and not so much at first. So I decided to change to one of the bigger medical, not a big hospital, but it was a conglomerate hospital in Jacksonville. And they were very strict on their rules and protocols. So when I did spinning babies, I would definitely or even when I got patients up to the bathroom who were on Pitocin at this one hospital that I worked at, they reprimanded me. They reprimanded me 3 times.
Because mostly, you were talking about this, right? You're in a bed pan. They want you to.
They wanted
just
to do a bed pan.
Once, yeah.
So anybody who was on Pitocin at this hospital had to be on continuous monitoring, which meant they had to use the bedpan, and if they couldn't use the bedpan, then they got a catheter. That was not a good fit for me. I worked there for 6 months to a year, maybe.
I mean, you really gave it a chance. I really tried to push through there.
Well, I was working part-time, so I was like, you know what, like I can handle this part-time. At the same time, I got my CLC, and I actually went and got trained to be a doula at that time, thinking that I was going to do a complete flip. And then I went to another community hospital who I really enjoyed a lot, and they were very supportive.
So
and
this other hospital pushed you to become even better?
They did.
Yeah.
They did. Well, there's some other things as well.
So why in Pitocin do they not let you get up? Because I know epidural,
it's not always the case with every hospital. It depends on their policies.
Okay.
But the thought process is with Pitocin. Pitocin is the hormone that your body produces to put you into labor, but it's an artificial form. So when we give Pitocin, we are causing contractions. When we're giving Pitocin, we can have too many contractions. So like I had too many contractions. When I had too many contractions, it doesn't give our baby enough time to kind of bounce back. So when they're getting squished with a contraction, it's like holding their breath. And then when you let go, then their heart rate usually will kind of come back, and that variability that we talked about would come back. But if we're giving contractions too close together, it can stress out our baby, and we can have dips in the heart rate or that like flat line that we don't like. So because we're giving Pitocin, we really need to monitor our baby continuously. If we're monitoring our baby continuously, that might mean that they can't go up to use the bathroom, even if it's just for a few minutes, because God forbid, during that few minutes, something happens.
So to get up to the bathroom, you're unhooking the monitors?
Yeah.
Because they're attached to a monitor beside your bed.
Yeah.
They're not. Okay.
Yeah, you're usually
They're not the portable ones like your little...
Correct. Yes, that hospital didn't have the
wheelie.
portable. Yeah, that hospital didn't have any portable monitors.
So it's not
now,
the Pitocin per se. It's
not
the monitoring that has to accompany.
Correct.
The
Yeah.
which isn't a reliable indicator to go off anyway, but you have to have it.
Correct.
Yes. Okay.
Well, yeah, it's a...
Okay, so now
It's a
you're
hard
in
thing.
community hospital, but you're a certified doula and a lactation consultant.
I went through my doula training, and I decided that doula I'd have to be on call all the time. I couldn't do that and be a nurse at the same time because I have my hours that are 12-hour shifts at the hospital. So
and you can't just leave because somebody's in labor.
Right. So I was struggling with that. So I didn't find that transition very easy. And then I had an interesting doula client who delivered on the bridge on the way to the hospital. And I had to accompany her to the hospital, and that did not look very good on my part. So I was like, okay, I really can't be a doula, but I can be doula trained. So I can act like a doula,
absolutely,
but in the hospital setting. And in my mind, I said, while the hospital setting isn't a perfect place to be, at least if they have me,
Yes.
and other people that are like-minded, at least then they'll have someone to advocate for them, someone who will try to get them moving, someone who cares about them. So I was able to kind of reconcile the fact that I really wasn't happy being a labor and delivery nurse because I saw interventions that I wasn't happy with. With all this new knowledge, I was able to reconcile it in my head that, okay, at least you have me there.
Wow, yeah.
And it was good. Actually, a lot of nurses, after I retook spinning babies, a lot of nurses that worked in the newer hospital that I worked at also got trained in spinning babies. So I felt like I was really excited because I was like, all right, I'm making a movement. This is a movement.
Yeah,
this is
make
good
a change.
Because you just
Yes.
think, like, if every nurse had that training, how different it would be for women.
It would
because you're not
be.
fighting against all the system. You now have people within it that are for you.
Yeah, and I think there's been movements, like a lot of registered nurses who work in labor and delivery now do recognize that and are advocating and are taking these classes. And I think they're kind of in the same spot where I was at, where they were like, well, it's not perfect. At least we're making a difference here in this.
And even for the nurses we've talked, like, you are under so much jurisdiction of you're required to report so many things. Like you said, even if with a swab, like, I have to do it legally, I'm binded, right? Like, your hands are tied to a huge extent. So it's not a like nurses are, thank God for nurses, but you're up against a lot.
Yeah. Yeah, we are, especially in the hospital system. And there's a lot of policies and procedures that, while are not perfect, do keep people safe. It's hard. It's hard.
How long is this before you start your own practice?
I took spinning babies, then I got doula certified, and then I got my CLC, which is Certified Lactation Counselor, because many people were like telling me how good I was at helping moms breastfeed and how great I was as an advocate. So I took my CLC, and then my mentor at the hospital was going to retire, and she encouraged me to get my IBCLC so I could take over for her. So I got my IBCLC. In the thoughts of I would move away from being bedside nurse in labor and delivery, and I would move more towards this head of lactation, and that I would make a difference in the postpartum world, because at the hospital we were doing breastfeeding support group once a week, and I had amazing patients, clients that would come back week after week that I was able to help. I was writing policies and procedures for postpartum and for breastfeeding, which was really great. So I was making some difference there. So I did take over for her, and I took over for about 2 years.
Can we say the hospital?
Yeah.
For this, I feel like I deserve a shout out. You're like, where? Especially here, I moved from Pittsburgh, so I don't know much here.
I worked at UF Flagler. At the time, it was Flagler Hospital in St. Augustine. It's still, I think, a really great place to deliver, in my opinion. They have midwives. I say we. I don't work there anymore, but they have midwives. They are VBAC friendly in certain provider groups. They are doula friendly. A lot of the staff are taught or have taken spinning babies. They have revised a lot of their policies and procedures to be supportive of natural labor. You can labor in the tub, which is not a great tub for delivering in, but it's nice.
But it's allowed.
It's allowed. Yes. And you can ambulate in labor. They have the portable monitors that are just like small monitors that are like you can walk around with.
So if you're in St. Augustine,
that's the place to be.
Go.
It is.
After having your support group, what made you start your new adventure?
I was so excited about teaching all the staff and doing all the things that I was doing as the head of lactation, and I was pioneering outpatient lactation visits because, again, my passion, I had that trouble with my son postpartum, so my passion became to help postpartum, and my boss came to me and said, we're canceling the outpatient lactation visits because they're not getting reimbursed by insurance and the hospital's losing money. So I took that upon myself to say, okay, well, if I can't do this in the hospital, then I'm going to start my own business and I'm going to do this for the community, because I really didn't know many IBCLCs in the community at all. I was gonna start that, so I started the practice because of that, and also because I became friends with home birth midwives and doulas, and they saw the care that I was giving their clients in the hospital, and they said, you know, you really should be doing this full time. You really should be doing this on your own. And I took their advice and their support because they were amazing and have been amazing, and started my own practice. And then my practice, it was supposed to be I was going to work in the hospital and work at my own practice, and then my practice took off and my passion for going into the home really grew, because I saw when someone comes into an office, they're presenting with just their problems, but you don't see the full picture of what's going on. So when I go into the home, I can help so much more. I can help get help set you up with a nice little station for feeding or pumping. I can really do an assessment of how are you doing, because when you present in a hospital or in an office, you don't present like you do at home. And I get to know my clients much better and form a relationship.
Right? You're not running against time.
Yes, and they're not time-based, so I get to spend a lot more time. Although in the hospital, that was one of the biggest complaints they had, was that my time management was not terrific, because I do really like to form a relationship with everybody.
Yeah, when you're talking lactation support, like some people it's more simple. And I remember having patients, you would go in and you're like, I was in there for an hour and 15 minutes, and you don't have that time, but you're like, I couldn't leave. You're just working so hard on that baby. It just takes a lot more support and education. Yes. And so it's so nice to not be constrained by.
Yes.
You're like dealing with a new baby, a new mom, right? Because it's like, it's
a big learning curve.
Yeah.
So what are the classes you offer?
I offer a childbirth class. I offer a prenatal breastfeeding class at the St. Augustine Birth Collective every month. I do one-on-one prenatal consultations, which I really highly recommend if you do want to breastfeed, and I do postpartum appointments. I also have packages as a full postpartum support, so I kind of do a little bit of everything. Yeah.
So your ideal client would be somebody that what?
I really love my clients that I have taught them prenatally, either the breastfeeding class or prenatal for childbirth, and that I've seen them every week afterwards. And I have clients that I've had for months, because it doesn't just end when I when our visits are over. So I keep touch with them. I have babies that are over a year old that I saw every week from before they had their baby on, and we have a really great relationship, and those are the ones that make me the most happy. And I love coordinating the care with my other like birth worker friends. So I kind of try to figure out like who personality wise or what needs do they need, and I'll bring in other birth workers to kind of help in the team. So I really like when there's a lot of teamwork as well.
It takes a village.
It does.
Right. We said it so much in your care team. When talking about building your birth team, we're like, it's like planning a wedding. You have a lot of people you need and a lot of knowledge because everything's new.
I think that's a really great analogy. It's even bigger
It's
than
even
your wedding.
It's so much less like time and attention, and it's
so much more important than your wedding. But then I did only have a very small wedding.
So you got it right. Okay, so what would you say to women like going into a birthing experience, maybe as far as what you recommend to prep?
I recommend having a team. I recommend reaching out to doulas. I recommend finding someone who you feel like you have a connection with. I recommend getting help prenatally for preparation, so taking birthing classes, taking breastfeeding classes, having things prepared, and having a team.
Get educated, right? Like get immersed in all what's coming up.
Know your options. Know that there's not just one way to do something, whether that's birth, whether that's feeding your baby, whether that's parenting. Like there's not just one way to do it. Do what works for you, but be educated on different options, because if you don't know your options, you really don't know what to choose. My poor little sweet client from this past weekend, she was like, everybody was so nice to me and said what a great job I was doing, and then they weighed the baby, and the baby's weight was 7.3% weight loss, the threshold's 8, and the lactation consultant in the hospital just she was like, they were great until things weren't going well, and then she just threw the milk at me and said, here, this is what you do now. And she was like, and so when she called me, she was like crying, and I was like, that was an awful way to handle that. That was just terrible. She's like, and they mentioned brain damage, and I was like,
oh my gosh.
Oh my God. I was like, okay, like back up here. Like, yes, your baby is a little bit jaundiced, but here's what they should have done. They should have said, okay, we're going to pump to increase the supply. We're going to bring the supply in. We need to make sure that you have a lab test in 24 hours. If we're going to send you home at all, we should do a lab test in 24 hours or make sure that that's going to happen instead of sending you home. Like, if it's that dire, why are we sending you home?
Very good point. Yeah, so then she could be so stressed out.
And they don't tell also like sunlight. That's not in the radar too, to help with jaundice as well.
So you became passionate about supporting women in their breastfeeding journey and postpartum, and it's so challenging in our culture because we're in a very much fed is best, do whatever culture, and certainly that is, but I heard one woman say it really well, like fed is minimum, that's a baseline. Of course you have to feed your baby. And so I think we're getting away from why would somebody, like breastfeeding is not the easiest thing in the world, and why is it worth it to breastfeed, and how do you navigate that in supporting women and just being compassionate in the care in a culture that's it's very sensitive and heated.
It is very sensitive. So I mean, I do follow Fed is Best. So I follow them on social media, and I think that the idea that started it was that there were some lactation professionals that were not recognizing big red flags. And they got to the point where some babies were in medical jeopardy, which is not the majority, but it is enough to cause alarm. So I understand the Fed is Best ideas. And I understand that postpartum is very high emotions, and it's it's very hormonally driven, and it's really difficult to breastfeed sometimes. And I do believe that we should support a mother's mental health. In that aspect, I do support Fed is Best. But what I think they didn't take into consideration was what we really need to do is provide more support. We need to provide support, medically driven support, where we're recognizing the big red flags. We can see when a baby is being underfed, and we can offer options to help them in that short period of time until we can get that milk supply up and get them to where they need to be. So I think the idea is not evil of Fed is Best. Neither is the idea of Breast is Best. Breast is Best comes from a really great place, because really medically we know breast is best. We know that the breast milk supports optimal gut health, provides protection long-term for autoimmune diseases, allergies, asthma. It provides long-term health benefits, which my generation, because we were primarily formula fed, don't have. And my generation has the most chronic medical conditions of any generation before, because we didn't have that beginning. We were given formula, or I was given formula from the very beginning. So we know that there are medical benefits long-term for the baby's health and for long-term health. But we need to make sure that we are supporting in the short term by giving good evidence-based information and getting mothers through that period to get them supported long term. And I think that's where Fed is Best didn't see what was needed there.
So again, going back to education, so that's why you want to go prenatal, have the education, and then postpartum, establish, right, like some relationship with the person that will support you in the breastfeeding journey, because it's not easy, and it's all mixed in with hormones and a new baby, and what do I do? And I can say personally, because of a breastfeeding class, that's all I had in my head after my baby was born.
Education and support in those first few weeks especially is crucial, and I think that's where the medical system has it wrong. I was just talking before about a client of mine that the weight loss was just a little on the higher side of normal, and the bilirubin, the jaundice levels were not high, but they were just a little more than what we kind of wanted at the hospital. Well, she was just discharged without any information and just given formula. If she hadn't called for some support and we hadn't gotten her to pump and supplement with her own breast milk and given options, she could have gone negatively into, her baby could have been in medical turmoil had she not gotten that.
Or she could have been done breastfeeding altogether.
Either way, right? Yeah. Like, it wasn't a good move on the medical system at that time, and I do feel like we do this a lot as the medical system. We're not
was this patient, you had her as a prenatal too?
I did a prenatal breastfeeding class.
So that what shows the importance of
and that she called. Prenatally. I waited a long time before calling and suffered a lot, and you're so right about the support. So do you feel like you could give, maybe to leave us as a little tease to more information on breastfeeding down the road, some things that women could do to set themselves up, and maybe their partner or people around them can be doing to support them early on, especially as your milk's coming in and it's so unknown and hard.
Big things that we can do as the mother is to do a lot of skin to skin, do a lot of hand expression, do as much feeding as possible. More stimulation increases the supply. I would recommend getting an electric pump and the proper electric pump prenatally, so that if there is any medical reasons that we have to increase the milk supply, because there are reasons why we wouldn't want to use that pump. I don't like to jump direct to the pump, but if we did need it, we have the supplies ready. Having a support person who has realistic expectations of the unfortunate lack of sleep in the first few weeks. Having people who can do things for you, like do your laundry, make you food, make sure that you are getting your basic needs taken care of so that you can provide those basic needs for your baby. Those are some key things that I think are really
I feel like it's hard. Yes, and it's so hard to let go of realizing how much your life is going to change and how much time you need to step back into typical roles. So hearing that where it's like, really, yeah, you need to outsource everything but bonding with your baby. And I think another thing you said that's so important that's often not known is, I think it's always to be like, just every few hours your baby should eat. When really those first few days
it's a lot.
Non-stop. It doesn't mean they're starving, but to bring in your supply, just hearing like your baby could be at your breast most of the time, and it feels crazy, but it won't stay off. Maybe it will, but
it hopefully won't stay
it will regulate, and then your baby will eat more meals. But that beginning it's a lot. Even as a postpartum nurse, I did not know how much that. Right, so I think to some women it can be like, oh my gosh, they're starving, I need to supplement. When really it's saying they're helping bring my milk in, they're telling my body how much to make, and that was huge that you said that.
Awesome, Alicia. Thank you so
Yeah,
much. We've learned so much with you, and this won't be the last conversation we have. You'll definitely come back to teach us more about breastfeeding and all the other stuff that comes with that.
Yes. And can you just tell everyone where they could find you online or to follow along?
I am LoveBug Lactation. My website is lovebuglactation.com. I'm on Instagram at LoveBug Lactation and Facebook at LoveBug Lactation.
Thank you.
The information provided in this podcast is not medical advice. It is anecdotal and for general knowledge and informational purposes only. It is not intended to substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of a qualified healthcare provider with any questions you may have. The use of this information is at your own risk.